Hi, my name is Greg Olson, and I'm the Director of the New York State Office for Aging. NYSOFA is committed to serving New York's diverse population, with particular attention to marginalized and underserved communities. We recognize that the Asian population is made up of many different communities representing different countries of origin, speaking different languages, and having varied cultures. We also know that faith-based outreach is often a good way to reach older adults in greatest social and economic need. In this video, we are very pleased to present a discussion with representatives of three prominent faiths in the Asian population: Islam, Buddhism, and Hinduism, regarding best practices to engage individuals and communities in a culturally respectful way.
The population of minority older adults is growing quickly. By 2050, roughly 42% of people aged 65 and older will identify as a person of color. By 2030, the number of people aged 65 and older who identify as lesbian, gay, bisexual, and transgender is estimated to double. Older adults from racial and ethnic minorities face persistent and pervasive health disparities. Health disparities exert a tremendous burden on family, caregivers, service providers, and healthcare delivery systems. As the aging population becomes more diverse, disparity-related costs and the toll of those providing care and services for older adults will only increase. Furthermore, older adults from racial and ethnic minorities will continue to face multiple barriers to accessing health and support services that will help them to age in place in the community. Patient-related barriers include limited English proficiency, low health literacy, varying levels of acculturation and assimilation, biases from westernized healthcare practices, mistrust of clinicians, inability to navigate the complex healthcare system, and cultural beliefs and taboos. We also know that clinician and service provider barriers also exist. Ageism, conscious and unconscious bias, and the lack of training in the principles and practices of providing linguistically appropriate and culturally sensitive patient care. Hi, I'm Millicent Miller. As we continue to unpack health disparities and health inequities in older adult populations to learn how we can provide effective, person-centered services, we've engaged a diverse group of stakeholders and leaders representing the diasporas that now call the state of New York home. So welcome to each of you, and thank you for joining me today. I would like for you to share just a little bit about yourselves before we get started today.
My name is Tarun Nagaula. I represent Hindu Temple, Albany. We are roughly around 5,000 families in the Capital District area, and it's one of the oldest Hindu temples in United States. It was in 1975 it is established. It's about 40 years old. One of the first time 10 temples in capital, actually in the entire nation.
That's wonderful. Thank you so much for sharing.
Thank you.
Dr. Paul?
I'm Monshin Paul Naiman, Reverend Monshin Paul Naiman, and I'm the abbot of Tendai Buddhist Institute, the Jishoku, which is the head temple for North America. And I'm a retired biomedical anthropologist and Asian studies specialist. And the temple that we have is actually the head temple, so I represent temples all over the United States, Canada, Puerto Rico, etc. Within our tradition, which is an East Asian tradition, it's Japanese tradition. And so the people who attend our facilities are a mixture both of Euro-Americans as well as Asian Americans, and Asian Americans, they tend to be East Asian, so Chinese, Japanese, Koreans, and Vietnamese.
Wonderful. Thank you so much for joining me. Dr. Shadi?
I will start with Assalamu Alaikum, which means peace be unto you. A good greeting and a good icebreaker for people that you go out to see. I am originally from Pakistan. I'm a physician, I'm a radiologist, have been in this area since 1971. When I arrived, actually my hospital paid for me and everything because the Vietnam War was going on and they needed more physicians, so a whole lot of physicians arrived in the country around that time. So I did my residency at St. Peter's Hospital, and we settled in the area. And the first mosque was built. It started around early, I'd say mid-70s, was completed in 1978. So as far as I'm concerned, I participate in all the mosques in the area. I have been very active with the interfaith, and I have known these gentlemen for years now. And I would like to update you on the community too, which has also changed. The American community around us has changed. The face of the population has changed. So has the Muslim community.
So now we're going to dive into our questions. Thank you so much for those warm introductions. So we understand that there are many cultural differences that are influenced by society and by faith. This can especially be seen in how members specific to communities interact with the most senior members and elder members as well. Can you describe how older adults are viewed and treated in your culture?
Most of the Eastern religions, they treat elders very respectfully.
Mm-hmm.
And we look after them, and especially the elders are actually provide a kind of a guidance, actually a guide to us. And that is with the westernization of the culture that is changing slowly, but unfortunately that is changing. Irrespective of it, still most of the elders are taken care of at their end of their life, and especially the immigrants who came here, we feel more attached to our parents and our elders than the first generation Americans, because that's how we grew up with.
Mm-hmm.
I mean, maybe I am assuming most of the community feels the same. And also, one thing I noticed, irrespective of the culture, some of it is these relationships are evolved based on the socio-economic conditions. Mm-hmm. Those play a major role. Mm-hmm. And for example, if you don't have the means to support, what do? That's where the actually the difference comes from the mm-hmm. Different backgrounds. And humanity is the same. It is changing slowly, even in India and here. And the way things are actually they're completely changing by the time and then by their experiences. And even in the US, I've seen the people who take care of their parents like everybody else. I mean, just like there's no difference being an Indian, an American, or mm-hmm. somebody else, Muslim or Jewish, or everybody the same. It just depends on the person and their how they look at their. That's where the faith comes into the picture. Mm-hmm. I mean, actually, the people who have got invested in the faith are more attached to their family than the people who doesn't believe in the faith. Mm-hmm. That I see that in the community.
I was just going to say that I agree with what Tarun was saying, but at the same time, I think there is a distinct difference between second, third, fourth generations. The more the immigrant communities become acculturated to America, the more they adopt the general American perspective because of the influence. I think one of the things that is a bit different is that especially early immigrants, they have linguistic challenges, mm-hmm. and so they depend upon the younger generations more, to the extent that the younger generation may actually be interpreting for some of their elders, which can actually bring problems when we're dealing with social services and healthcare, because some of the terms that are used are not easily translatable.
Right. Right.
And additionally, the younger people, when they have adopted the American methods and the American medical system, whereas some of the elderly have not. It's not that they don't. It's not that they eschew it entirely. It's just that they're still really tied to whatever the medicines were at home, whether it be Ayurveda if it's in India, or whether it's Kampo if it's in Japan, or Chinese medicine, etc. And so how to negotiate that can sometimes cause some difficulties between the generations. Mm-hmm. Oh, Grandpa, why don't you just do this? And Grandpa is going to be insistent upon, no, that's not what we do. Mm-hmm. And so that can bring up some real issues within families, as well as between social services and medical care.
Exactly. Our basic culture, or how we deal with things, depends on the religion more. So the Quran is very clear about, after the worship of the one own God, the next is the taking care of your parents. And people take that very seriously. And there are many sayings from Prophet Muhammad that also allude to taking care of the parents. You know, one man came to him and said, "Oh, Prophet, I put my mother on my back and I took her for pilgrimage. Did I pay off her debt?" And he said, "No, you will not be able to pay off her debt." So it is very strongly recommended, and people take it seriously, to the extent that you really don't find a lot of senior homes or nursing homes in that part of the world. And of course, when we come here, things change. The first generation is different from the younger ones. But if they learn it early, they try to keep it going. For instance, my son and my grandson just insisted on dropping me off instead of me driving here today.
So in terms of the treating of older adults and elders within your culture, is there a difference in that depending upon if the individual has lived in the United States or in New York for some time versus those who have come recently or that may not be native born?
I think there's an incredible difference. Mm-hmm. And it's as Dr. Chaudhry was alluding to, within Islam there's a strict injunction. In East Asia there's also an injunction. The children are expected to take care of their parents, and that is directly related to ancestor respect and what's often referred to as ancestor worship, although I would argue it's not ancestor worship, but that's often. So that the way one treats one's parents will determine one's rebirth, because rebirth is a common feature in East Asian religions. And so that's going to have a direct result. And because of that, then people are going to view how they take care of their parents in this life and in the next life as very important. But again, as we get farther away from the first to second to third generation, that diminishes. Now, having said that, what I find, and it'd be interesting to see if they find the same sort of thing, the second generation is going to go farther away. The third generation is going to return to it. It seems to be the pattern of not only Asian populations, but immigrant populations in general. So the first generation that's born in America will want to Americanize and become less like the homeland. Mm-hmm. The grandchildren and the great-grandchildren all of a sudden find a greater importance to those things. So you see, it's not just a linear diminution of caring for the elders, but it sort of goes in a wave between generations as they spend time here.
And Dr. Chaudhry, do you find the same, especially in that sort of cycle of returning back to culture.
Completely.
Yeah, it is entirely true. You know, this ebb and flow of, you know, how not even our faith traditions, but others as well. But up to your question, the first generation born here will try and keep the values. They come from a background where medical health may be not the same standard as here, but it's not as expensive as here. So as time goes on, people either due to both husband and wife working with children and stress for time to be able to take care of the elderly, as well as monetarily, are not able to do that. So they will then have to extend naturally to what's available to them in the society, which means, you know, agencies like yours, the healthcare agencies that can help them. And for that, again, the immigrant or faith communities that have migrated more recently find it difficult to navigate. And like you had mentioned earlier, you know, we might need special services to reach that population.
Yeah, actually, that's a very valid point, actually, what Dr. Chaudhary mentioned. I think for that, the best solution is going to be, it has to come within the community, in the sense, having a representative from the community brings a lot of comfort for the people. And that's what it is. I think the government has to invest in the communities rather than some programs outside. If they invest in the communities, the reach will be much deeper and then much broader, rather than having an office coming and telling that we're going to provide it. It's not going to work that way because of the cultural differences. And some people may be hesitant to even ask for help culturally, especially from the Eastern community. I mean, even in the temple, we see that people definitely need the help. We try to help them. Somebody, they have the pride, they don't want to take that. So those things only done through the community better than any outside thing.
Can I just add to that, because as they were talking, it reminded me that there's a tendency, I think, for state agencies, federal agencies, whatever it may be, to, with good intent, to try to meet the needs of the community, but sometimes they don't identify the needs as well as people within the community. And so one program that I work with, which was a minority health initiative, we went into the Akwesasne Indian Reservation, and we didn't say, here's what you need. We asked them, what do you need? And we identified their pattern and then worked with them in a way that in which the assistance came out of the needs of the people as the people perceived it, as opposed to the needs as we looking in might perceive it. And I think that's where faith communities can have a real impact, because they're working within the community, and we can talk among each other in a way that someone else cannot speak to you.
Absolutely.
And I think that becomes a really important aspect of the programs.
And we do a lot of activities, not just for the Hindu community, outside the community also. Every year we conduct health fairs, and sometime in April, May timeframe, we do conduct every year. And then we conducted a COVID vaccination camp where we were able to do 450 vaccinations in a single day.
Definitely. So that's a great segue into our next question. As you've mentioned, the importance of identifying with and connecting with and really embedding in the work that we're doing, and not just, I think oftentimes we do a lot of intervening on or providing services to, as opposed to working with specific communities. And so we've talked about some of the needs that you're finding within your various cultures and communities. And we all need help at different points in our life. I think we can all agree to that. So it could be assistance for basic needs like food and shelter, but as we age, we become less independent over time and more reliant upon our family members and members of our community. And this can be very challenging to reconcile with, giving up some level of independence. And so what would you say are the most pressing needs for older adults living within your community?
If I can go through a list, I sort of had a list in my mind about food being number one, and shelter that we can provide or at least help with. Also, there's a Muslim food bank and there's a Muslim soup kitchen, which have good programs. Every now and then they might need some assistance. We try as a community to get those going and keep them going, and it's been very successful. So besides the food and the shelter, you might need clergy services, you might need transportation to get to maybe the hospital, maybe the doctor's office, maybe groceries, or maybe just go to the services at your faith-based, your facility, to the mosque or whatever other functions they may be. Transportation is important. And a clergy, that may go around and check on people and see how they're doing. So mental health, especially after this pandemic, people are shut in more than they ever used to be. Mental health is a need, for the community, particularly the elders.
Yes, Chaudhary mentioned, loneliness is the number one. Number one problem we are facing.
Awareness, yeah.
And about the next one is the food, and because they're kind of used to certain kind of food, and they cannot cook, somebody has to arrange it from locally, and you can't buy it from the store, especially the ethnic foods, and somebody has to prepare them. And we do have a brunch program at our temple every week and Sundays, and sometimes we know there are some elderly people who cannot help, and the community members, so sometimes we do arrange, take turns, then provide food. It's not that they don't have, they need help. It's not about the help. They need that kind of a service at the time, we can say that. The sense of there is actually, I can't give the names, but there is a gentleman, they didn't have any kids, but they were there about for 90 years, and he was one of the top awardees from the GE. And she was a physician, and then she passed away recently, about 2 years back. They were lonely. So we were able to arrange for the community, the volunteers, and then the food. And they had, all the help they had, but they had this in-home help, and then they paid from their own pocket. They didn't need any assistance, anything. They paid whatever these things are there. They're very wealthy. But still, the loneliness, and then having the food, they're kind of very religious. They are wanted to eat certain kind of a food. They have a requirement of not having any spices, and then only vegetarian. And they were, it's like completely religious food. It's kind of a very, it's very simple, basic, but you won't get it anywhere.
Right.
Unless somebody has to prepare.
Yeah.
Those kind of things we have to, it has to be through the community. You can only provide to the community. There is no way agency can come and do anything unless you have the faith-based institution supports you. There is no way you can provide that kind of a service.
And if I can, just to expand on that just a moment, I think that from a cultural perspective, East Asia, and I think it's true of other Asians here, if you ask an East Asian, Chinese, Korean, Japanese, Vietnamese person, a male especially, if you ask them, is there anything you can do, they'll say no. They're not going to volunteer, yes, I need something. It's not part of the cultural context. And so therefore, working with people within the community, because I can identify the people in terms of the needs, but if you ask them, they won't volunteer it.
Yeah.
And so sometimes, and I think it's true with all three of our traditions, sometimes it's better to say, we're going to do this, as opposed to saying, would you like to do this? We're going to do this activity together. We're going to, I have a men's group that goes out, and these are all widowed men, and we get together to have lunch. And it's not because they can't provide their own lunch. They don't have special meals they need, but I know that they need the companionship, and they're not going to ask for it.
Those are all great points, and I applaud you for mentioning the social isolation aspect. I see that as an issue that transcends culture, and we see that as adults age and the disconnectedness and what effect that has on their health and well-being, their mental health, their physical health. And so as we think about those things, and even going back to an earlier point of maybe not even having the words culturally to express how someone is feeling, can you share more about maybe the mental health aspects, and how can those types of programs and services, like what is needed in order to even begin those conversations of providing mental health and social connectedness support?
I think the mental health issues, especially, I think you have to identify the people. Every now and then, maybe a program at the religious facility, at the mosque or a church or the temple, to make people aware of what may happen as you get older. So some specialists who might speak to the community, they may be from the community itself or outside specialists, just to make people aware of what's going on and what is out there that can help them. So I think the whole thing is connecting with the people and developing trust, and letting them know there's things out there that can help you. And of course, as younger caregivers can identify that and help them through with this process, I think that would be important, to just bring those programs to the facilities, that where a large number of people gather. For instance, on a Friday prayer, on an average, the four large mosques in ICCD, there may be close to 250 people. In the one in Latham in Waterville, the Al Hadaya Center, 500 plus. So there is large gatherings like that where you can reach people that you can ordinarily not be able to reach. So, and I had talked to the Imam about it, and I said, would you make an announcement if we had a program? Or the management, and he said, certainly we would do it. I do it at the end of the sermon, or the management runs, gives a program for the week or whatever. The management at the end of the sermon usually come up and say, this is going on, we can offer this, or the prayer times are such and such, and it can be announced. And I think if we do such programs, it would be very beneficial to the elderly.
We do at the temple, yearly health fair, we do have a psychiatric booth. And the community members, they do come and help. And whenever they need an appointment, any kind of a service, we can arrange for the temple. In the community we are arranging right now. And there are psychiatrists who wants to volunteer, and then they are volunteering, and they do provide services confidentially. And it's one of the biggest challenge. The problem is, how do they have to accept they have an issue. That is the major challenge. Rather than, the providing the service is the easiest thing. But identifying the problem, the need, that is the biggest challenge for us. And I am hoping that, that is the same thing in every other community also. It's a human nature. It's nothing to do with the religion.
Right.
It's a human nature.
I think East Asian is a little bit different insofar as, and I make a joke about this, but it's not funny, and that is that in the Capital District of New York probably has more psychologists, psychiatrists, and social workers than all of Japan.
Yes,
Because the idea of what we think of as psychotherapeutic process is alien to East Asian peoples in general. And so therefore, you might identify an individual and you can think to yourself, that person should really see someone. It's going to be very difficult for them to accept that that is going to be something they're going to do. They're going to be, I'm talking about more elderly, not so much, second, third generation is a different issue, but first generation into second generation, East Asian populations are not amenable to what we would think of as psychological care.
It's true, and a lot of our cultures, from where I come from, they're multi-generation homes. The 3 or 4 generations living together. So the elderly there, they have their own, what they do with the grandchildren. The young ones don't need to get babysitters to take care of the kids when they go out. So that multi-generational households that used to be the norm, I come from Pakistan, so I'll talk about, and I'm sure India the same way, we're losing that, right? So we're becoming more individualistic, the nuclear family. There's more stress just in the nuclear family itself, let alone the elderly. We are all under stress. So I don't know, I've been talking about, let's go back to that old system. My son and his family live with me. I enjoy it, it's wonderful. But there are days that I'd say, why do I live here?
Well, and we might even say that Auntie was the psychotherapist.
And so
it's true in East Asia.
Yeah, and so my point was that living together is sort of a therapy for all of us.
Yeah.
And I think when the elder people live with the younger family or grandkids, that is sort of a therapy. And yes, it is very hard to get the people from my community to go out and see a psychologist or a psychiatrist.
Yeah, therapy is a foreign word for us, most of us, to be honest with you. Initially I didn't even understand what therapy means. But we never needed a therapy in the sense, we all had the support system when we grew up.
Right.
We never even thought about it. Till you come here, the loneliness brought all these issues. Mostly thing is having that independence, not depending on each other. That causes a lot of social issues.
Right.
That's what it is.
I find it really interesting that I lived in Japan for 6 years and have a temple in Japan, and as I said before, you're not going to find very many psychologists, psychiatrists. There is a form of psychological, I wouldn't even call it psychological therapy, but something that was close to it in Japan. I won't go into the details on it. But the person is much more likely to want to go and speak to the village priest than they are to a formal therapist. Because not only do they know that person, but, and here's an important point, they know the family. And so from an East Asian perspective, I think it's true of all, the thought is not of oneself, the thought is of one's family. One sees oneself in the context of the larger family and village organization rather than as autonomous individuals. As we become autonomous individuals, we think of our own psychotherapy. If we think of ourselves as part of the family unit, as Dr. Chaudhry was saying, then we realize that going to the imam or going to the priest or going to that person understands the family dynamics. You don't need to explain a lot, and you can just say what you feel, and sometimes that being able to express it is sufficient.
Yes.
You don't need a therapy the way we would think of therapies. Just being able to express it and having the person sort of tweak around the edges. Now, also there's an expectation that the imam or the priest or whomever it may be is also going to, knowing what's going on, work his or her magic in a particular fashion.
Very much relational.
Yeah.